So we have 5 minutes for each station. डॉक्टर नवीद को अनम्यूट कर दो 1 मिनट। जी सर, over to you. So this is the first case.
Yes, so Assalamu alaikum, Dr. Osama.
Walaikum salam, sir.
So just look at the picture, read the station, and let me know when you are finished. I mean, when you're ready.
Yes, sir.
So can you please describe the radiology?
This is an MRI brain, which shows T1 axial as well as C1 cycle cuts with IV contrast. There is a heterogeneous enhancing area in the area of pineal region, which shows an internal forwards at that area.
So you said it's enhancing. How do you know it is enhancing when you?
Yeah, there is other vessels, peripheral vessels are taking contrast. That's why I can say that it is enhancing.
So you do not have a T1 without contrast. So
yes,
of course you have. Okay. So what do you think its most likely diagnosis is?
As the age is 21-year-old, so I would think that either it is meningioma or it is glioma.
So any other differentials that you have in your mind, or glioma ke alawa?
There can be germinoma.
Okay.
There can be a pineal area tumor with pinealocytoma.
Okay. So what are different type of these tumors that you are talking about? What I mean, और क्या ज़हन में आता है?
In that area particularly, there can be a tumor that arises from pineal area. There can be a tumor that arises from multiple embryonal cells, which can be a germinoma and non-germinoma cells. It can be a teratoma over there.
Okay, so what is your probable diagnosis? These were differential, of course, but what is your probable or most at the top diagnosis?
Most top diagnosis. I would say that it is germinoma.
Okay, so why do you think it's a germinoma?
Because the age is 21-year-old, it is heterogeneously enhancing.
Okay, so what are your treatment options in germinoma, or what you are expecting?
After getting a relevant, specific, and baseline investigation, I would like to request for alkaline phosphate, beta HCG, and alpha fetoprotein. If any one of these will be enlarged, so my suspicion will strongly positively bend toward my diagnosis, and then I can go for further my steps of taking a biopsy and then sending this patient for radiotherapy if ever it will be positive.
So what would be your probable, how would you take a biopsy? What would be your surgical approach in this case?
Biopsy can be taken either through an open method or through an endoscopic method or through a stereotactic biopsy. They are the three ways we can do an open.
So how would you take an open biopsy?
Open biopsy is the tent is deep in line and it is infratentorially. Then at the area of pineal region, we can take open biopsy from supracerebral infratentorial approach, or we can take it from supracerebellar from interhemispheric transtentorial approach.
Okay. Any other approach if you want to go supratentorial?
Supratentorial, there are suboccipital supratentorial approach, interhemispheric approach, posterior corpus callosal approach, and anterior corpus callosum approach.
Sir, last
So
30 seconds.
yeah, so any prognostic factors for this tumors?
Yeah, if we will have alkaline phosphate, alpha fetoprotein, and other things will be positive, then it will show that it is very radiosensitive tumor after radiation.
Okay,
The prognosis will be better.
okay, so how would you follow up? When would you follow up?
Then would I follow up? I will follow up with the tumor markers in the same time. I will have after 3 to 4 weeks I will have MRI brain again to see
Okay, thank you.
if the tumor is regress.
Okay.
Thank you, Dr.
Thank
Naveed
you,
and
sir.
Dr. Osama.
Thank you, sir.
सर आपको पे दोबारा भी लेंगे हम next
Yeah,
candidate.
that's okay. I was thinking about it because एक मर्तबा cases खत्म हो जाए, then we can come up the
Yes,
small
we can
things
discuss.
that we think. Yeah.
Yes, yes, we can discuss. So, Dr. Saqib, you will be taking the next candidate, and Dr. Musaddiq, you will be the candidate. So, I'm unmuting Dr. Musaddiq and Dr. Saqib. Over to you, Dr. Saqib.
Yeah, Assalamu alaikum, Dr. Musaddiq. Can you hear me?
Yes, Dr. Sakib.
Okay. So we'll start. You can just quickly read the command, the one-liner.
Yes, sir, I read the one-liner.
Okay. Can you please describe the radiology, the images provided?
Sir, these are the MRI with contrast, and these are the axial and the sagittal images which are being shown over here. And in that, there's a well-defined globular lesion that is seen at the base of the anterior skull base, and that is homogeneously enhancing. And also going back also going back towards compressing about the structures at the back also. So this is the
Okay.
radiology. So
Okay. Are you sure that you would say these are homogeneously enhancing?
yes, sir, this is homogeneously enhancing lesion.
Okay. Dr. Farooq, should I also correct alongside, or should I just keep on asking the
No,
question?
just keep questioning.
Okay. Okay. So, Dr. Musaddiq, what is the most likely diagnosis based on
So
this radiology?
most likely diagnosis as a refractory group meningioma.
Okay. And is there any other differential as well?
So it could be tuberculum shalai meningioma, it could be esthesia neuroblastoma, and also could be a fungal infection as well.
Okay. And have you heard about Foster-Kennedy syndrome?
Yes, sir.
Can you describe the what it is?
Sir, it's actually ipsilateral atrophy controlated by platinum with anosmia, ipsilateral side.
Sorry, can you repeat? Ipsilateral, what did you mention? Ipsilateral?
Ipsilateral optic atrophy controlated by papilledema with anosmia, ipsilateral anosmia.
Okay. So, based on the differentials which you mentioned, what is the usual blood supply of these lesions?
So these lesions are usually supplied by the anterior and posterior ethmoidal branches of the ophthalmic branch of the internal carotid artery.
Okay. And is there any role of preoperative embolization in these kind of lesions?
No, sir. There's no role of interpretive embolization in these lesions.
Okay, and if what if you see this patient in clinic and patient has decreased vision, loss of smell, what treatment option would you advise?
Sir, after a proper history and clinical examination and clinical and neurological examination and after all past lines, and, uh, I would go for surgery in that case.
Okay, and what would be your approach for surgery?
So approach in this case would be a bifrontal approach. Bifrontal
Okay,
subfrontal approach would be the approach in this case.
okay, and thank you. I think Dr. Farooq.
Yeah, it's last 50 seconds. कोई और सवाल आप
Okay,
करना चाहते हैं या कमेंट कर देना कोई मसला
so Dr. Farooq, if the patient asks you that after surgery, will my vision and loss of sense of smell improve or get better, how would you answer?
Uh, um, it depends upon the timing of the surgery and the patient presentation, how long the patient has presented. If the patient is early presented, then there are good chances of preservation of smell and there are good chances of recovery of the vision. If the patient is presented late, then there are little or minimal chances of preservation of smell and recovery of vision.
Okay, thank you.
Okay, thank you Dr. Musaddiq and Dr. Sakib. Dr. Sakib,
Yes.
kindly stay connected.
Okay.
Okay. For next, we have Dr. Pirasad. He will examine the candidate, and the candidate is Dr. Mamuna. Dr. Mamuna, are you here? Because there are so many people who are not with their names, so it's very difficult to call them. So, yes, he's not here. Ji, Dr. Jawad, I guess we can do it this way. Let me unmute you. Just a second. Dr. Asad, 1 minute. Yes, you may unmute.
अस्सलाम वालेकुम फरूक भाई, क्या हाल चाल है? तबीयत ठीक ठाक आपकी?
Alhamdulillah. Dr. Yasin is also with us. So thank you, sir, for joining us. So this is the station for you, Dr. Jawad and Dr. Pirasad. You will examine.
सही। जवाद साहब स्टेशन रीड करें एंड आफ्टरवर्ड्स काइंडली रेडियोलॉजी पे कमेंट करें।
So this is T1-weighted axial view which show a hypo to isointense lesion in the fourth ventricle area. There is also an image which show a sagittal image which show contrast image which show a heterogeneous contrast enhancing lesion in the fourth ventricular area compressing the brainstem, and there is associated hydrocephalus.
सही। So what do you think it is?
I think, sir, it is arising from the floor, so it is most likely medulloblastoma.
Okay. So how would you manage your case and justify your findings?
Sir, I will first put VP shot
First of
in
all,
this case.
justify your radiological findings, then manage.
Radiological finding is, sir, it is a fourth ventricular tumor with contrast enhancement, and I will do VP shunting first in this case, and after a week or two, I will do a suboccipital craniectomy and excision of tumor.
Okay, you can directly go for excision of tumor, or you can describe a bit more. Can you describe more regarding management?
Sir, I will put the patient on steroid.
Okay, so what could be the steps of those surgery?
The step, the patient will be positioned in a prone position, and I will do a suboccipital midline craniectomy The incision will be from the E9 up to the C2 lamina, C2 spinous process, and then I will do craniotomy. The upper limit will be from the transverse process, and the side limit will be sigmoid sinus. And then I will open the dura in Y shape and broad microscope into the view, and I will remove the tumor through telovelar approach.
Okay. So would you remove the growth totally, or you can take it in piecemeal, or how will you do it? What would you do with the prana magna?
I will, sir. I will after opening the dura, I will drain CSF from the cisterna magna. That will make the brain relax, and after that, sir, I will remove it in a piece meal in under neuromonitoring, sir. Brainstem auditory work potential and neuromonitoring, sir.
Okay. So what would be the complications for the surgery?
Complication could be, sir, bleeding, injury to the surrounding neurovascular structure, sir, and there could be a CSF leak, sir.
Any other?
And unable to graphically remove the tumor, sir.
Okay. What about brainstem?
The tumor stick to the brainstem. We will not remove it, sir. We will leave it.
Okay, you can leave it, but are there any complications related to it?
Yes, sir. The brainstem, there can be a respiratory difficulty, sir, eating difficulty, and cardiopulmonary difficulty, sir.
So, what are the overall prognostic factors? How is it overall prognosis, and what are the important prognostic factors?
The prognosis depend upon the age and the extent of resection, sir, and the type of genes and histological grading, sir. If it is a high grade prognosis, the 5-year prognosis is 53%. But if it is a standard group, the prognosis is more than 65%, sir. आप म्यूट है सर. आवाज नहीं आ रही.
जी डॉक्टर असद आप हैं हमारे साथ? कि योर टाइम इज अप वैसे भी आप अनम्यूट. जी डॉक्टर
अच्छा,
असद.
इसमें मैं फाइनली कमेंट करना चाहूंगा. अच्छा, इसमें जब रेडियोलॉजी के लिए जैसे हमने आपसे कहा, तो हमें सर यही बताते थे कि आप इसमें थोड़ा सा डिफाइन करें, फिर जब मैंने आपको जस्टिफाई करें तो आप उसमें बता देते मेरे ख्याल में कि जो फैक्टर्स है, जैसे भाई फोर्थ वर्टिकल से आ रहा है, उसके अलावा जैसे कोई सीएसएफ की साइन आ रही है, कोई बनाना साइन वगैरह, जैसे उसको रूल आउट भी कर सके ना, तो कुछ इस तरह का ये भी बताना था हमें. अच्छा, इसी तरह स्टेप्स जब आपसे पूछे जाए मैनेजमेंट में, तो कोशिश करें कि स्टेप्स पूरे बताएं, क्योंकि समटाइम्स हमें ये होता है कि आपको तो आ रहा है लेकिन एग्जामिनर को नहीं पता कि आपको कितना वो आ रहा है, तो वो बेहतर होगा कि अगर आप बताएं. इसी तरह जो है रेडियोलॉजी है, रेडियोलॉजी में डिफाइन करना बेहतर रहेगा. बाकी अल्हम्दुलिल्लाह ठीक है. और जैसे वो एक T1 पे देखें, एक कैल्सिफिकेशन लग रही है या क्या वाइट जो हाइपर इंटेंस है, इस तरह की चीजें आपको मेंशन करनी चाहिए जब आप बताएं रेडियोलॉजी, तो उसको डिस्क्राइब प्रॉपर्ली करें. बाकी ठीक है भाई, जज़ाकल्लाह.
थैंक यू सर.
Thank you, Dr. Jawad and Dr. Pirasad. Dr. Asad, you stay with us.
जी जी.
Dr. Abel will examine the next candidate, and next candidate is Dr. Iqbal. So let me unmute Dr. Iqbal. जी डॉक्टर इकबाल आप अनम्यूट कर लें.
अस्सलाम वालेकुम.
जी डॉक्टर आबिद, ओवर टू.
हेलो, आवाज आ रही है मेरी?
यस.
अस्सलाम वालेकुम.
वालेकुम अस्सलाम. अच्छा, this is your scenario. Can you read the scenario and then answer the relevant questions?
जी मैडम.
Can you describe the radiology?
So this is a MRI spine, dorsal spine with a sagittal and axial images with contrast images. showing a single lesion, which is most probably intradural extramedullary, and this is bearing scale not available. Uh, this lesion is heterogeneously contrast enhancing with many fluids area seen inside the lesion, and this lesion is pushing the cord to one side.
Okay, so you have not told me the level of the lesion. Can you comment on the level of the lesion as well, based on the radiology?
Madam, I can't comment upon the level of lesion.
Okay, so what are your differentials?
So most probably this is a differential include schwannoma, neurofibroma, meningioma.
Okay, and what is your most likely diagnosis in this case?
Most probably this is a schwannoma.
Can you name the grading system which is used to describe these lesions?
This is a Sazamoa et al.
What is the grading?
So in grade 1, this is totally intradural. In grade 2, this is a intradural and extradural. In grade 2B, this is a extradural and foraminal. And in grade 2C, this is foraminal and extraforaminal. And in grade 3, this is intradural, extradural, and foraminal. And in grade 3B, this is extradural, foraminal, and extraforaminal. In grade 4, this is multi-direction.
Okay. So can you tell me the difference between a neurofibroma and a schwannoma?
Sorry, madam.
Okay. And now what is the further work that you will do in this patient?
So I will do the baseline investigation for optimizing into surgery. I will also go for plain X-ray if we are planning for fixation for instability post-op.
Is there any relevant work that you will do to exclude neurofibromatosis in this patient?
जी डॉक्टर इकबाल
Sorry, madam.
Can you tell me any orbital manifestations of neurofibromatosis type 1?
ऑर्बिटल में ऑप्टिक डायोमास होते हैं और स्पेनाइड विंग डिस्प्लेसिया
उसके अलावा
और एक्सोप्थेल्मस और लिस्ट नड्यूल भी होते हैं.
सही.
जी डॉक्टर राबिल और कुछ सवाल कुछ आप पूछना चाहती हैं?
Criteria
we
can
can finish it.
NF1 diagnosis. What is the criteria?
NF1 के more than 6 capital spots होती हैं in prepubertal age 5 mm और postpubertal में 15 mm होती हैं. लिस्ट नड्यूल्स होती हैं और एक्सिलरी या इंग्वाइनल फ्रैक्टिंग होती है और स्पेनाइड विंग डिस्प्लेसिया और ऑप्टिक नर्व डायोमा और
ठीक है. Thank you.
Thank you, Dr. Iqbal and Dr. Rabil. Dr. Yasin, sir, आप next candidate को examine करेंगे. Dr. Ahmed, you will be the next candidate. You can unmute and let me unmute Dr. Yasin.
Yes.
जी sir. So this is the next station. जी Dr. Ahmed.
जी Yes, sir.
जी Dr. Yasin. You have the questions. सर आप अनम्यूट हैं डॉक्टर यासिन आपकी आवाज नहीं आ रही है मेरे. सर आपकी आवाज़ नहीं आ रही है मैं, ऑल्दो यू आर अनम्यूट, बट आपकी आवाज़ नहीं आ रही है मैं। सर मैं जब तक डॉक्टर तनवीर को सेशन के लिए लेता हूँ, फिर आपको मैं उसके बाद नेक्स्ट के लिए ले लेता हूँ। सॉरी आई कांट हेयर यू एक्चुअली। जी डॉक्टर तनवीर, मैं एक आपको म्यूट कर दूं। जी डॉक्टर तनवीर,
आवाज
स्टेशन 5। अनम्यूट करें डॉक्टर तनवीर। डॉक्टर तनवीर, आप एक बार क्लिक करें, अनम्यूट हो जाएगा वो, आप उसको डबल नहीं करें। No.
मेरी आवाज आ रही है?
Yes, we can hear
हाँ
you.
जी,
So station 5.
आवाज आ रही है मेरी?
जी जी आपकी आवाज़ आ रही है, कैंडिडेट इज विद यू।
ओके ओके। हाँ, कैंडिडेट का नाम थोड़ा सा प्लीज।
डॉक्टर अहमद।
डॉक्टर।
डॉक्टर अहमद।
ओके, डॉक्टर अहमद, प्लीज see this radiology.
Yes, sir. I've seen
Have
it.
you seen? Okay,
Yes,
then
sir.
describe this radiology.
Uh, जैसे MRI brain, T1 plain and T1 with contrast images and T2 images axial cut showing hyperintense lesion on T1 and which is ring enhancing lesion on T1 with contrast, and in T2 there is the heterogeneous contrast enhancing lesion along with perilesional edema and midline shift towards the left side.
Good. Anything else?
Uh,
Okay, so after seeing this radiology, what are your differential diagnosis?
it can be the cerebral abscess, or it can be neoplastic lesion.
Hmm. And okay, what kind of neoplastic lesion you're suspecting?
It can be the high-grade glioma.
Okay. Only high-grade glioma?
It can be,
Okay. So what are the different stages of this pathology?
sir, the patient has the well-defined capsule. So
Hmm.
my first diagnosis is cerebral
No,
abscess.
no,
Then
you are not.
patient is a
No, are not getting my point. I am saying what are the different stages of this pathology?
What are different stages of
sir,
this pathology?
जी, first is the early cerebritis stage, which lasts for 1 to 3 days, and second is the late cerebritis, then is the early capsule, and fourth is the late capsule formation.
Okay. So what are the treatment options?
That we will give first we will treatment depends. First we will start medically. We will
Hmm.
give patient IV antibiotics, and we will give steroid, give anti-epileptics, and then after preoperative anesthesia fitness, we will uh, needle aspiration and craniotomy and STN after therapy.
Okay. And what are the contraindication to surgical treatment?
Uh, if the patient has multiple comorbidities and anesthesia fitness of the patient is if he is unfit for the surgery, or it is any present on the eloquent area, then we will treat with medication.
Okay. So, Dr. Ahmed, can you tell me the different pathogens which cause this pathology and what is the most common pathogen?
Most common pathogen is Streptococcus pyogenes, and others are Streptococcus pneumoniae, and it can be the Strep aureus or epidermidis or Streptococcus malaria, angiogenesis, pneumocystis, and any fungus candida albicans.
Okay, if this patient is immunocompromised, say for example he is the known case of AIDS, then what would be the most common organism?
That will be the candidiasis.
Okay. Acha, after seeing this radiology, can you differentiate between the cerebral abscess and METs and glioma?
Yes, sir. It can be differentiated first on the basis of MRS, and second on the basis of first on the basis
No,
of
I am
radiology.
asking on the radiology. How can you differentiate?
Yes, on the basis of radiology, abscess will have the well-defined capsule, which will be regular.
Hello.
And while a glioma patient will have irregular and ill-defined capsular lesion. Second, age of the glioma will be in the 40s, and there will be no history of associated fever.
ओके जी डॉक्टर तनवीर कोई सवाल और है क्या? ओके थैंक यू डॉक्टर अहमद एंड डॉक्टर तनवीर.
थैंक यू वेरी मच.
डॉक्टर तनवीर आप हमारे साथ ही रहे. सो नेक्स्ट डॉक्टर यासीन, मैं आपको दोबारा से ट्राई करता हूँ कनेक्ट करने की. जी मैं आपको अनम्यूट कर रहा हूँ. डॉक्टर अबूजर, काइंडली टर्न ऑन योर वीडियो. आई मीन कैमरा एंड लेट मी अनम्यूट यू. डॉक्टर यासीन आप जी सर. डॉक्टर यासीन, कैंडिडेट डॉक्टर अबूजर इज विद यू. आपको आ रही है आवाज? सर आपकी आवाज अभी भी नहीं आई है गैस. सर मे बी देयर इज सम प्रॉब्लम विद परमिशंस. जब आप इसको कनेक्ट करते हैं पूरी मीटिंग को, तो उस वक्त शुरू में आपसे परमिशंस मांगता है फॉर ऑडियो. सो वो शायद आपको देनी होगी, इस वजह से नहीं हो रहा ये. एंड वी आर अनेबल टू हियर यू. डॉक्टर फातिमा, यू विल बी द एग्जामिनर. आपको अनम्यूट करूं. So this is the scenario, Dr. Abuzar. I hope you have read the scenario and now you can answer
Yes.
Dr. Fatma. You, Dr. Fatma?
Assalamu alaikum, Dr. Abuzar. Am I audible to you?
Yes.
Yes. Okay, describe the radiology.
This is CT angiogram, which shows bilateral ICA and vertebral artery and basilar artery, and there is a globular aneurysm which is present at the bifurcation of the MCA. There are perforator which are rising from the aneurysm. It is globular in shape, and the direction of the aneurysm is, I cannot appreciate the direction, but there are multiple perforators which are coming from the aneurysm. And there is hypoplastic of ACA.
Okay, perforators. Okay. So what is your diagnosis?
MCA aneurysm.
Okay. Name the different segment of the involved vessel.
It is involving M2, and it is present in the bifurcation M1 and M2 junction. there are three junction which is M2, M3.
Can you describe them further? Like when you are saying M1 and when you are saying M2, M3.
M1 is started from the at the junction of the bifurcation where its ICA bifurcate. It start from the ICA to M2, where MCA bifurcation start, and M2 is started from the bifurcation to where a MCA M2 where come to the bifurcation.
Okay. What are the commonest complication of subarachnoid hemorrhage?
Commonest complication are hydrocephalus, vasospasm, or rebleed.
Anything more you want to add?
And there is these are three most common complications which come in after subarachnoid hemorrhage. Hyponatremia.
You have
It could
time.
be
Think about it. Think about it. You may divide complications, in like medical complications, immediate complications, and late complications. Think about on these lines.
on a medical complication. There could be hyponatremia or seizure.
More early and
And
late. Can you divide them in these two?
yes, I can divide it is early or late. In early stages, there is a patient present with seizure or vasospasm and hyponatremia, hydrocephalus.
So when does vasospasm starts?
It started from the day 5 to up to day 7 or day 8.
Okay. So what are the advantages and disadvantages of clipping versus coiling?
Clipping versus advantage of clipping is if patient is young or if there is a dome and neck ratio. If there is a dome and neck ratio is a more than a 2.5, then we should go for coiling. Or it
And I'm not asking for the indications of clipping
yes,
versus coiling. I'm asking advantages and disadvantages of clipping one patient rather coiling, or vice versa.
if we go for clipping, then there are complications regarding surgical point of view. Or if we do a coiling, then there is less chance of complication.
Like what complications? Do you want to be more specific?
In this scenario, if we go for coiling, then it is a chance because there is no neck available, so it could be a occlude all the vessel perforator of the MCA.
For example, if this patient has an intracerebral hemorrhage,
Yes,
right, and it's causing mass effect. So what is
yes.
preferred option, coiling versus clipping?
Clipping it is a preferred option because clipping is the best option
Why?
because during operation we can remove the hematoma as well. We can also preserve uh, we can also preserve the as he is as this aneurysm is causing mass effect, we can reduce the mass effect by complete clipping.
Okay. Thank you. I think that's all.
Yeah. Thank you, Dr. Fatma and Dr. Abuzar. Dr. Fatma, if you could stay with us, I hope we will take you for next sessions. Dr. Yasin, I hope this is connected now. And Dr. Irfanuddin, you will be the candidate. Dr. Masood. Yeah. सर एक मिनट में आपको कनेक्ट कर रहा हूँ सर देखें आप अनम्यूट करें
ठीक है, अब आवाज आ रही है मेरी?
Yes, sir. Yes, sir. We can. Dr. Irfan, sir, let me take Dr. Irfan. Dr. Irfan, आप kindly कैमरा अपना ऑन करें so that I can see you. I don't know, Dr. Irfan, आप किस नेम से हैं? Because यहाँ पे आपका नाम तो शो नहीं हो रहा. Is Mustafa with us? So we can take Dr. Mustafa for now. Dr. Mustafa, kindly connect to your audio. जी Dr. Mustafa. So this is the
जी अस्सलाम वालेकुम।
station 7. Station 7. जी डॉक्टर यासिन.
ठीक
डॉक्टर
है।
मुस्तफा आपको मैं म्यूट कर रहा हूँ, आप खुद को म्यूट ना करें.
Mustafa, Mustafa, are you ready?
Yes, sir.
ठीक है, Mustafa. You can see this MRI image with you. This is a patient, a 64-year-old man with a non-small cell lung cancer, and he presented with the headache and seizures for 3 months. You have to counsel the attendants.
So, should I explain the imaging findings before?
No. You
Oh.
just need to start the counseling.
So, to me, this lesion appears to be metastatic, likely, and I will counsel the lesion. First, I will counsel the attendant and patient that regarding the disease status of his primary condition. What do they know about it, and whether is there any systemic disease or not, systemic spread or not. So, patient has isolated lesion on scan. So, I started counseling him regarding the indication of surgical resection of this lesion, and because of its isolated location, and if there's no other disease, disseminated disease present in the body. So, I will my suggestion recommendation to the family attendant would be for surgical resection of this lesion.
Okay. And what about the rest of things? What else would you tell them?
So the risk of there will be risks include with the resection, because risks including motor sensory deficit, risk of bleeding, infection, and further regarding we might not able to completely resect the lesion, might resort to only biopsy after depending on intraoperative findings, and I might need to send frozen section intraoperatively to better the pathology.
So
And
what about what would you say the diagnosis is?
So my primary impression and would be that this is the metastatic disease, likely a metastatic disease, and it's so there's a non-small cell lung carcinoma. So I expect it to be radiation resistant, and surgical resection of the isolated lesion would be the most appropriate choice for this patient.
Okay, and what about the prognosis, life expectancy?
Sir, regarding that, again, it will require further details whether is there any disseminated disease, and if there is a disseminated disease, it's a metastasis the stage 4, but if there is any systemic spread of disease, that might limit his life expectancy. But oncologist would be a further opinion will be required from oncologist.
Okay, right. ठीक है. अच्छा, what will be the surgical steps and the risk and benefits of surgery?
Sorry, I missed your question.
इसमें ये बताना है कि क्या सर्जिकल स्टेप्स हैं, क्या रिस्क बेनिफिट्स हैं.
So, surgical resection. So, I will plan navigation guided, perform right temporal craniotomy, and aim for maximum safe resection of the lesion. And I will preferably get intraoperative navigation MRI for this. And position would be supine with head
Can you
tilted.
brief? Let's keep it brief. We have to counsel the attendants, so we just let them know okay, what's happening, or just a brief introduction of the surgical procedure, कैसे करेंगे, and then कि अच्छा ये risk and benefits हैं, ये prognosis है, and then if they agree, then you will tell them about surgery. ठीक है, you don't have to tell them that मैं ये करूँगा and पूरी फैमिली को एक्सप्लेनेशन ही देना है कि क्या डिटेल सर्जिकल स्टेप्स होंगे. You just have to let them know that surgery is going to be from here. ठीक है, probably this is going to be the incision, and after a few days he will be discharged home if everything remains uneventful, है ना?
Yes, yes, sir.
ठीक है, ठीक है.
Okay, thank you, sir.
So,
Sir, kindly आप हमारे साथ रहिएगा. We will take you for next station, sir.
Sure.
Okay,
मैं
Dr.
just
Irfan. जी सर, sorry.
मैं आपको ज्वाइन करता हूँ वापस.
Okay, sir. Thank you, sir. डॉक्टर इरफान आपको मैं अनम्यूट कर रहा हूँ, एंड डॉक्टर नवीद को मैं अनम्यूट कर रहा हूँ. आई गेस ही इज ऑलरेडी अनम्यूटेड. जी डॉक्टर इरफान.
Hello, Assalamu alaikum, sir.
जी वालेकुम
Walaikum
अस्सलाम.
salam.
So this is the
Irfan,
station.
just read the scenario and let me know when you're ready.
डॉक्टर इरफान आप माइक को हाथ में हाँ होल्ड कर लें. जी
Yes, sir. Yes, sir. आवाज आ रही है मेरी, सर?
जी डॉक्टर
जी.
नवीद.
Yeah, so
जी सर.
just describe the radiology, please.
Sir, these are the MR images of axial and coronal, multiplanar, and multi-sequential images of a patient, 25 years old. It's showing a single regular hypointense lesion on T1, and also on it's a hyperintense on T2, and
Okay, so
yes, sir.
based on your radiology, what's your differential diagnosis?
Sir, my top differential on top in my differential diagnosis, sir, it could be an arachnoid cyst, as it's following the CSF signals.
Okay, any other differential diagnosis?
Sir, it could be an hydrated cyst, sir.
Okay. Why hydrated cyst?
Sir, because it is hypo on T1 and on diffusion weighted images, sir.
Okay, so tell me what other investigation would you do to further delineate or further help you out in this?
Sir, it could be dermoid or epidermoid, sir. So I will go for diffusion weighted images, sir.
Okay, or how would it help?
Sir,
मतलब क्या देखना चाहेंगे डिफ्यूजन वेटेज में, क्या आपको मिलेगा जो आपकी हेल्प करे?
Sir, whether it's showing me any kind of restricted diffusion or not.
So diffusion restriction है कि नहीं है, उस बेसिस पे अगर है तो क्या?
Sir, yeah, I will exclude some other pathologies like if it is epidermoid, sir. So I can differentiate it on that one, sir. There will be dermoid and epidermoid.
So मैं यही पूछना चाह रहा हूँ कि अगर डिफ्यूजन रिस्ट्रिक्शन है तो आपके
sir.
जहन में क्या चीज क्लियर होगी?
Sir, that would be epidermoid, sir.
Okay, so अगर डिफ्यूजन रिस्ट्रिक्शन है तो, और नहीं है तो of course then you'll have
Yes, sir. That would be arachnoid cyst, sir.
What other types of lesions do you suspect it in this same area? Pretty much the same question, but
Sir,
yeah,
it could be, sir, and porencephalic cyst, sir.
Mm-hmm.
And that could be a meningioma, sir. But I will differentiate it on the under scans.
Okay. Just tell me, how would you treat this patient?
Sir, sir, I will do a cystoperitoneal shunt, sir, in this case.
Cystoperitoneal shunt. And how do you know that this is, I mean, आपकी probable diagnosis क्या है? What is your
Sir, if I found
topmost
it to be
diagnosis?
arachnoid cyst, sir.
Okay, so
Sir,
you
my
think,
topmost diagnosis in this case is arachnoid cyst, sir. So,
so arachnoid cyst अगर आती है इस एज में, 25 साल की एज में, so you'll do a cystoperitoneal shunt right away.
most probably, sir, I will go for that.
क्या इंडिकेशंस क्या होंगी आपकी कोई भी इंटरवेंशन करने के लिए? रेक्नॉइड सिस्ट अगर आप जहन में रख रहे हैं तो आपकी इंडिकेशन क्या होंगी?
Sir, if it's causing any midline shift and causing a mass effect, and if it's causing a seizures, then I will go for that to decompress the area and improve the neurology, sir.
Okay, so शंट के अलावा कुछ? Okay, that's okay.
Sorry, sir.
ठीक है, your time is up. We'll discuss further then.
Hello, sir.
Okay.
I can also do endoscopic penetration, sir.
Thank you, Dr. Irfan. Your time is up. So next is Dr. Mashal and Dr. Saqib. आप उनको एग्जामिन करेंगे. Let me unmute Dr. Saqib.
Assalamu alaikum, Dr. Mashal. Are you there?
जिसे मैं एक मिनट को अनम्यूट कर दूं. जी डॉक्टर मशल. ये बाकी डॉक्टर मशल आपके साथ में 2-3 मोबाइल और हैं, शायद उनको आप म्यूट करवाएं पहले. जी डॉक्टर मशल.
So Dr. Mashal, you can see the screen. Quickly read this, the 3 lines written over there.
So this is MRI cervical spine showing
Dr. Mashal, your sound,
डॉक्टर
your
मशल
voice is not clear.
आपकी आवाज नहीं आ रही डॉक्टर मशल.
axial cuts. There is hypointensity that can be appreciated at the level of. Hello?
जी.
Yes, we can
Continue
hear you.
describing this radiology.
Okay, so there is a hypointensity that can be appreciated at the level of C5, C6, and the lesion is present at the posterior margin of the vertebral bodies in this space, and it is causing compression effect on the canal and displacing the cord posteriorly. And on axial images, there is hypointensity that resulting in the obstruction of the CSF flow on left side and resulting in the compression of the canal towards the right side.
Okay, you mentioned the what level you mentioned? Which cervical level is involved?
6, 7.
Okay, and so in your based on these findings, what is the most likely diagnosis?
Uh, it's degenerative disease. It's the herniated cervical disc.
Okay. Before moving on to next question, you should also have mentioned loss of cervical lordosis on the sagittal section of MRI. So, what are the different treatment options if we continue with the diagnosis that it's a degenerative process and disc osteophyte complex? What are the treatment options?
Since we can opt for the medical management and surgical management.
Okay, please describe
Hello?
further. Okay, Dr. Mashal, you mentioned medical and surgical management. So, can you describe
Yeah.
a little detail?
Okay, there are options. We can either go for the conservative management. In conservative management, we can opt for the pain management of the patient, and also we can go for the physical therapy, and we can go for the muscle relaxants. And apart from that, we can either opt for the surgical management, in which we can go for either anterior approach or posterior approach.
Okay, can you mention the names of the anterior and the posterior approach which you think should be done?
Okay, so in this patient, we can go for anterior cervical discectomy and fusion.
Okay. Can you quickly describe major steps of anterior cervical discectomy and fusion? Just major steps.
Yeah. Okay. First of all, I'll counsel the patient regarding the treatment option, and then I'll take written and informed consent, and
Just
then
quickly
I'll
mention
shift the
the
patient
major
to.
steps. In talks, you don't have
Okay.
such time that you mention everything.
Okay. I'll say. Okay, I'll make the position of the patient. I'll place the patient in supine position and with neck slightly extended. Then I will mark my region of interest under fluoroscopy, and then I'll perpendip the patient, and then I'll mark my incision. That will be just anterior to the anterior border of the sternocleidomastoid in an oblique fashion, and it will be anterior to the C6, C7 level, and then I will do the
Your time is up.
dissection, vascular dissection. Okay.
So Dr. Mashal, in talks, the time is very short. There are only 5 minutes. So if the command is to mention major steps of procedure, you don't have to start from counseling and then positioning and everything. You just have to mention that after confirmation of the level and supine position, anterior neck incision will be given, followed by a muscle dissection. We'll reconfirm the level, followed by discectomy under microscope. And then once we visualize the thecal sac as well as the nerve roots, we'll perform hemostasis and place an interbody graft or a PEEK cage, and then we'll move towards closure of the wound after hemostasis. So this is how you mention the major steps of a procedure. In case of a long case, you mention each and everything in detail, but not on a talks station, because then you lose time. And now there was another question as well regarding complications, but because of shortage of time, that question could not be asked. Okay.
Thank you, Dr. Sakib.
Welcome.
And next candidate is Dr. Walid, and Dr. Rabel, you will examine him. And the next station we have is station 10. Let me unmute Dr. Rabel. Just a minute. जी डॉक्टर आबिद
अस्सलाम वालेकुम।
वालेकुम अस्सलाम।
Can you please read the
डॉक्टर
scenario?
वलीद आप थोड़ा सा जोर से बोलना होगा आपको, या आप नजदीक हो जाए।
अच्छा
Kindly
जी
read the
डॉक्टर
scenario.
वलीद,
एक मिनट मैं हैंड फ्री बदल दूं। एक मिनट सर।
आ रही है आपकी आवाज, आप बोले।
अस्सलाम वालेकुम।
Walaikum assalam. Kindly read the
हेलो
scenario. Can you hear me?
हेलो
Hello, can you hear me?
डॉक्टर वलीद
हेलो
आपको आवाज आ रही है? जी डॉक्टर वलीद,
हेलो
आपकी आवाज आ रही है डॉक्टर वलीद।
क्वेश्चन रिपीट कर रहे हैं सर?
Kindly read the scenario first.
ठीक है।
Okay. Can you describe this radiology?
This is the MRI scan, axial and sagittal view T1 and T2 weighted, and it shows closely dilated lateral ventricle and on the axial cut, and on the sagittal cut it shows the dilated lateral ventricle as well as third ventricle. I
Okay. What is the
cannot. Diagnosis is hydrocephalus, and keeping the scenario in the mind, it is obstructive hydrocephalus,
Okay. So
communicating hydrocephalus, sorry.
what are the different treatment options in this case?
Treatment option is ventriculoperitoneal shunt, ventriculopleural shunt, and ventriculoatrial shunt.
Any other option?
ETV is controversial in this case as it is post-infectious.
Okay. So what is the ETV success score of this patient? Keeping
ETV success score in we have age, we have a previous shunt, and we have marks for the pathology. And for the age, for less than 6 months, we give 10 point, then up to 10, 1 year, it's 20, and then up to 10 to 10 year, 30, and for more than 10 years, 40 points. And then shunt, previous shunt, if it is not shunted, then 10 point, and if it is shunted, 0 point. And for pathology, we give 20 points for myelomeningocele and infections. And for tactile, for non-tactile pathology, and for tactile pathology, we give 30 points.
What would be the
We
score
add
in
these points, and it will give us the percentage of success in 6 months.
What is the ETV success score in this patient?
40 and 20 and 70%.
Can you tell me the steps of ETV?
As it is grossly dilated ventricle, we can go from the transcortical approach, and we'll do the burr hole at the Coker point, and we will use a peel away catheter. And after hitting the ventricle, we will see in which ventricle we have stimulated from the help of thalamus striate and anterior septal vein. And then we will go through the foramen of Monroe to see the floor of the third ventricle. And we will fenestrate the third ventricle anterior to the mammillary body. We will fenestrate the tuber cinerarium, and we can do that with the endoscope, or then we will fenestrate. We can increase the fenestration from Fogarty's catheter, and also we can open the Lilliquist. We will open the Lilliquist membrane to confirm the flow of the CSF.
What are
After
certain features? Okay, so what are certain features that you would look on the radiology to assess whether you can go for ETV in a particular case?
We will see the basilar artery, where basilar artery flow wide, where is the basilar artery flow wide, and the interpeduncular fossa.
So your time is up.
Thank you.
Okay, thank you.
Thank
So
you.
next, Dr. Majvi, and along with her, the examiner will be Dr. Tanveer. Let me unmute both of them. जी, Dr. Tanveer and Dr. Majvi. Station 11.
Okay, Dr. Majvin, are you ready?
Yes, sir. Sir, so
Yes, describe this
40
radiology, please.
yes, sir, 42 years old male RTA. Okay, sir, this is CT scan brain plane. CT scan brain plane axial cuts, which shows a hyperdense crescent-shaped lesion in the on the right side of convexity of brain, and it is hyperdense, and depending on as its appearance, it looks like to be a hematoma, subdural hematoma, as it is crossing the sutures, and it is overall along the convexity.
So what is your diagnosis?
Acute subdural hematoma.
Okay, so what are the different treatment options for acute subdural hematoma?
So there are multiple treatment options, but the standard is decompressive craniotomy and durotomy.
Decompressive craniotomy or cranectomy?
Craniectomy, we actually take out the bone flap and store it after 3 to 6 months we can do cranioplasty. In craniotomy, we replace the bone flap.
Okay, any other treatment option?
So it depends upon whether if it is a chronic subdural, then we can go for single burr. We can also go for through and through with twisted craniostomy. But in this case, as it is an acute subdural, so craniotomy will be, or craniectomy will be the first choice.
Okay, so what are the appropriate dimensions of cranectomy in decompressive cranectomy?
At least it should be 12 centimeters, but 12 to 15 centimeter is really adequate.
12 to 15 centimeter.
Yes, sir. Minimum should be 12 centimeter, because otherwise it would not provide enough room for decompression.
Okay, so what are different options to save the bone?
So it depends intraoperatively. If we see that the compression is not resolved after evacuating the hematoma, we can store the bone in the abdomen, or we can either keep it in a separate container in frozen condition.
And what should be the ideal storing temperature?
-4, I guess. I'm not sure. Sorry, sir.
Okay. Okay, tell me different type of cranioplasty substitute.
The cranioplasty, there are multiple types of cranioplasty. There can be synthetic mesh cranioplasty, and there can be. So one is that we can put the bone itself, and the other is we can actually make customized bone based on the 3D reconstruction of the patient's skull. And other is intraoperatively we can use bone cement and do the cranioplasty.
Okay, and can you tell me when should be bone flap be replaced ideally?
So ideally we can do it after 6 months, but it depends upon whether the condition of the at that time, if it is this in this case the bone will not be infected, so we can do even after 3 months if we can.
Okay, what is Trefine syndrome?
So Trefine syndrome is defined as when the patient when craniectomy is done and there is a defect in the bone, the patient can present with any symptoms. The syndrome of Treffinite. The patient can have headache. Patient can have obviously psychological problems because of cosmetic defect. Can have any symptomatology, and this is because of the removal of the bone that creates the defect. And yes, so that's it.
Okay, thank you.
Okay. Thank you, Dr. Tanveer and Dr. Majavi. Dr.
Thank you.
Sajjad, you will be the next, and I am unmuting Dr. Yasin.
Yes, sir.
जी डॉक्टर यासिन
जी आवाज आ रही है?
Yes, sir.
Yes, sir.
ठीक है. Right, Sajjad, this is a 27-year-old male presented with a history of mild neck pain and difficulty gripping objects, along with walking difficulty for 4 months.
Yes.
क्या रेडियोलॉजी बताइए?
Yes, sir. This is the MRI T1 weighted images sagittal section, which is showing an herniation of the cerebellar tonsils below the foramen magnum, causing compression effect on the CSF signals. And other than that, I could not appreciate hydrocephalus. For that, I also want to see the axial sections to see the temporal horns of the same patient. And in these images, I can appreciate there is tonsillar herniation below the foramen magnum.
What's the diagnosis?
Sir, most common Chiari malformation type 1.
Chiari malformation type 1. Acha. What are the different types of pathology? What are the different types of Chiari malformation?
First is type 1, this Chiari, which occurs in adults. Other is the type 2, which occurs mainly in children's associated with MMC. And the other one is Chiari 1.5, which have features of type 1 as well as type 2, in which there is a herniation of the brainstem and the fourth ventricle and opex below, but there will be hydrocephalus. And other the type 3, in which there will be an occipital encephalocele, in which the cerebellum as well as the fourth ventricle and the brain contents will herniate. And the fourth one is the in which there will be cerebellar hypoplasia. And there is also a type of
Okay, tell me what are the different theories about Chiari malformation? Can't hear you.
And small posterior fossa. Mainly there are, hello, sorry.
Yes.
Sir, are you asking about the theories of the Chiari malformation?
Yeah, can you tell me the theories?
Sir, there are mainly three theories, in which first is Gardner-Waterheimer theory, which states that due to the systolic blood pressure, due to pressure from the cranium, due to the pressure which shifts the cerebellar tonsils below the foramen magnum. The other one is due to the Valsalva maneuver, which due to the pressure from the cranium, it pushed the cerebellar tonsil as well as obstruct the CSF pathway and causes syrinx. The third is the old house field theory, in which there is accumulation of the fluid in the perivascular area, for which it may be associated with syrinx.
Okay. Tell me, what is the treatment?
Sir, in type 1 of Chiari malformation, the main treatment is posterior decompression with the removal of the adhesions which are present, and to maintain the normal CSF flow through the foramen magnum.
Achha. Tell me, what are the different techniques of posterior fossa decompression? इनमें different techniques है ना? So can you explain?
Yes, sir. Sir, we mainly do the perimeter and we expose the foramen magnum and make a Y-shaped durotomy, and after that we remove the adhesions which are present in the foramen magnum and try to make the way for the CSF. Other than that, we can also do the duroplasty also there
What
to
about
make.
tonsillectomy?
Yes, sir. Tonsillectomy is also performed if the CSF flow is not established. In those cases, we can do tonsillectomy also.
How much should be the craniectomy size?
3 by 3 centimeter.
All right. Acha, if this is the same patient that comes to you, but she complains of having headaches and visual blurring, so what will you do?
Yes. Patient with visual blurring.
Yes.
Maybe patient having hydrocap, so I will procedure so for purpose because patient having brainstem compression due to hydrocephalus.
So what will you do first?
Sir, first of all, if the patient come with the signs of raised ICP due to the hydrocephalus, we address that. But the optimal treatment will be the posterior decompression to make the for the patency of the CSF flow.
If there is anyone with hydrocephalus, what will you do?
For VP shunt, we can do.
So first of all, you proceed for VP shunt.
Yes, sir.
Okay, and if the symptoms resolve, then that's okay.
Yes,
If the
yes,
symptoms do not resolve, then what will you do?
then posterior decompression of foramen magnum, sir.
Right. You will first of all you will reassess the patency of the shunt
Yes,
and the
yes.
shunt is functioning or
Yes.
not. And
Yes,
then
yes.
the symptoms are more suggestive of brainstem compression, and the shoulder numbness and paresthesia and cape-like anesthesia, which is suggestive more of brainstem compression. Then you will proceed with posterior fossa
Yes.
decompression.
Yes, sir. Yes.
Okay. Complications.
Thank you, sir.
Okay.
Complications,
Thank you,
sir.
sir.
CSF link and these things.
जी डॉक्टर सजाद आपका टाइम पूरा हो गया डॉक्टर यासिन you kindly stay with us, we will take your comment at 5:50 inshallah.
I'm sorry, I have to leave. Yeah, I'm so sorry, I have to leave.
Okay.
Okay.
Thank you so much, sir. Thank you.
Thank you.
Dr. Naveed, kindly आप next session ले लें. And we have the Dr. Talha. Dr. Talha, are you here? जी Dr. Talha, I'm unmuting you.
Okay, Dr. Talha, please read the scenario and let me know when you're ready.
Assalamu alaikum. Can you hear me?
जी.
Yes, we can hear you. Can you turn your camera towards you?
जी तलहा आपके सामने स्कैन दिख रहा है आपको?
Yes.
So just read the scenario and let me know when you're ready.
Young male patient. Okay, sir.
So can you describe the radiology, please?
Sir, on the very right, this is X-ray open mouth to odontoid view, showing the linear fracture at the base of odontoid. In the middle, I have the CT scan coronal cut showing odontoid fracture from the base of the odontoid, and similar finding I can appreciate on the sagittal CT scan.
So what do you think the pathology is in this case?
Sir, odontoid fracture.
Okay, so how do you classify this pathology?
Sir, it's classified according to Montisano-D'Alonso classification, and it's the type 2 odontoid fracture according to the Montisano-D'Alonso.
Okay, so how based on that classification, how do you treat the patient?
Sir, as the patient is the young male, I will.
Sorry to interrupt. According to your classification, what type this is?
Sir, type 2.
Type 2? Okay,
Yes,
so
sir.
how? Any further classification? Okay. So
Sir,
how would you treat this patient?
sir, I will immobilize the patient in the rigid orthosis and follow the patient after the 4 week to look for the fusion and get X-ray cervical AP and lateral view to look for any instability. And if it is going towards the fusion, I will follow the patient clinically, neurologically, and radiographically. And
Okay. So any other treatment option that you have?
yes, sir. Other options are hello brace immobilization, and also we can go for the surgical fusion.
Okay. So what surgical option in fusion you have?
Sir, we can go for open reduction and anterior odontoid screw fixation.
Okay. So can you describe the procedure of odontoid screw fixation?
Uh, for odontoid screw fixation, the position of the patient should be supine. After that, from consent, I will shift the patient to the OT. Position of the patient should be supine. I will give the incision in the neck at the angle of mandible, and confirm my level under the fluoroscopic guidance. Uh, After having the dissections, subperiosteal dissections, I will keep the trajectory from the anterior inferior part of the C2 to the towards the superior posterior part, including the fracture line.
Okay. So how would you confirm your placement of your screw?
Under
Just give me just 2 or 3 complications of this procedure.
Okay, sir. The complication is hardware failure. Exposure-related complication include injury to the vasculatures and pseudoarthrosis and hardware-related complications.
Okay. Thank you. Thank you.
Thank you, Dr. Naveed and Dr. Talha. Last 2 stations, and the next station is with Dr. Kamal, and Dr. Abel will see as a examiner. Yeah, Dr. Kamal, can you hear?
Hello. जी सर, हेलो.
Assalamu alaikum.
जी वालेकुम सलाम.
So you have to define the following landmarks and answer the questions which I'll be putting forward to you. Okay. So can you tell me the anatomical location of the caucus point? What are the anatomical landmarks that you will identify to reach the caucus point or to identify the caucus point?
Madam, caucus point we define it's an
Dr. Kamal,
11
आपकी आवाज कम आ
centimeter
रही है.
behind the Nazian, 3 centimeter. Sir, it is 11 centimeter behind the Nazian, sir, and 3 centimeter from the midline and 1 centimeter anterior to the coronal suture. And facial point, sir, it is 6 to 7 centimeter above the anion and 3 to 4 centimeters lateral to the midline.
Can you tell me the direction of passing the external ventricular drain in both the caucus and the Fraser's point? What is the direction that we will use?
Madam, in from the focal point, and we head towards the ipsilateral medial canthus and the contralateral external radiatory matrix, and from the Fraser point we head towards the middle of the forehead, mid of the forehead.
Okay, and can you tell me the anatomical landmarks to identify opisthion?
Madam, it is a posterior margin of foramen magnum.
Okay, so what are McRae's and Chamberlain's lines?
Ji, madam.
McRae's line.
Mackerel line, madam, it is from Bayesian to Opisthian.
And Chamberlain's line?
And Chamberlain, madam, it is from Opisthian to the hard palate.
And what is the difference between Chamberlain's and McGregor's line?
Madam, it is Chamberlain. It is from Bayesian to Opisthian, and hello,
Yes, and McGregor's line?
madam, it is from most caudal point of the hard palate to the most inferior caudal point of the posterior part of the foramen magnum.
Okay.
Opisthian.
Okay, and how will you identify the entry point for a transpedicular screw on the L3 vertebra?
Madam, I will draw a line from the superior facet of the inferior vertebra vertically and from the mid of the transverse process, and I will keep the screw medial 3 into 5, 15-degree medial. Hello.
What is the difference between the screws used in open and minimally invasive method?
Madam, difference between the screws? I didn't get your question, sorry.
What is the difference between the screws which are used in open method and the screws which are used in minimally invasive method?
Madam, minimally invasive method, they are cannulated in the high-pitched screws, and the open method, they are not cannulated.
Okay, thank you.
Thank you.
Okay, thank you.
Thank you.
So for next station, this will be the last station, and Dr. Tanveer, मैं आपको unmute करूँ. We will examine the candidate, and candidate is Dr. Abuzar Rauf. बाकी लोग kindly mute कर लें अपने आप. So I'm skipping few stations, and I'm going to this station. Okay.
Okay. So who is with me?
Dr. Abuzar.
Dr. Abuzar, आपको आवाज आ रही है?
जी सर आ रही बात.
Okay, so please review the scan and answer the question. Should I ask?
Yes, sir.
So please describe this image.
This is MRI brain corneal section contrast enhancing image showing there is a homogeneously enhancing lesion which is involving the bilateral ICA, and speedily it is compressing the ventricle. I would like to see other images also. And inferiorly it is going into sphenoid sinus.
Okay, so what is your diagnosis?
Cellular supracellular lesion.
So what would it be?
Or
It's an infective lesion?
it is a neoplastic lesion.
Which neoplastic lesion?
Jesus, sorry.
Which neoplastic lesion you are suspecting?
Pituitary adenoma.
Okay, pituitary adenoma. ठीक है. So describe the two commonly used grading system for this lesion.
There are two common grading system, which is a Hardy classification and Kenos grading.
Okay, so can you tell me according to Knox grading, which grading it is?
Kenos grading, it is a grade 3.
So how you can say that it's a grade 3?
Because it is involving the whole ICA.
Okay. So can you tell me the common complication of transfemoral surgery?
Common complication of transfemoral surgery are CSF leakage, subarachnoid hemorrhage, or a tumor bed bleed, or DI, or hormonal imbalance.
Anything else?
And infection.
Okay. So, what measure you will take to prevent the CSF leak after transcranial endoscopic excision?
After a procedure,
No,
if there is no,
I am saying that after surgery or after endoscopic excision, if patient present with CSF leak, so what you have, what
okay.
are your different options?
First, we will manage conservatively by giving medication, or if it is not settled, then we will go for a lumbar drain. We will drain CSF for 1 to 2 or 3 days. If it continues to CSF leakage, then we will reoperate either transcranial or either by transcranial.
Either transcranial. So, what will the option in transcranial approach?
Transcranial option, there are two options, extradural or intradural.
Okay, so tell me what type of workup you will done in this case?
Which workup?
Before surgery, you have only this
Yes.
investigation or the MRI. What any further workup you require for this patient?
I will go for visual field workup or a endocrinological workup. And
okay, in endocrine workup, what are the 3 most important hormones you want?
I want prolactin level, cortisol level, and CTH, a growth hormone level.
Growth hormone level.
Or it's a growth hormone, a CTH, or a thyroid level.
Right. So, okay. If in the endocrine workup, patient has decreased cortisol and decreased TSH.
Yes. Then I will replace the thyroid hormone. I will give thyroxine, or I will also give a cortisol replacement before surgery.
Okay. Okay, thank you. I guess your question is finished. Thank you, Dr. Tanveer and Dr. Abuzar. So
Thank you.
On the demand, we are taking Dr. Musharraf and Dr. Saad. Dr. Saad will examine Dr. Musharraf.
Thank you, Dr. Farooq. Can you hear me, Dr. Musharraf? Can you just look at the
Yes,
scan
sir.
and are you there?
Yes, I'm here. I can hear you.
I hope you're not driving.
No, I'm not driving. I'm just sitting in the car.
So, Dr. Saab, can you look at the images and tell me what do you see?
This is an CT scan brain on the left side axial cuts, and then CT angiography, and an angiogram on the right side. And,
Is it an angiogram? Is it
Dr.
Saab, is it a DSA or is it a CT angiogram?
No, it is a DSA catheter angiogram.
How do you know this is a DSA?
No, catheter angiogram.
Sorry?
It's a catheter angiogram.
This is a catheter angiogram. Okay, so what do you see in the CT scan, doctor?
I can see hyper densities in the subarachnoid spaces on the axial CT scan,
On the
and
exit.
on the CT angiogram I can on the axial CT scan brain, and I can appreciate an aneurysm at the junction of at the terminal part of ICA.
On the basis of CT scan, what do you think is the diagnosis?
It's a subarachnoid hemorrhage.
This is a subarachnoid hemorrhage. So can you tell me the different grades and classification for subarachnoid hemorrhage? And can you tell me the significance for those classifications?
Like you want me to tell you the classifications or the grades?
So you can start with the grades. And what are the significance of those grades? I mean, so Hunter-Ness
So
classification is one.
yeah, we have
What is
no, I
okay?
have
Yeah.
like I will explain the classification and the grading system.
Okay.
So we have this Hunter-Ness classification is one. It is divided into 5 grades. In
Mm-hmm.
the first grade, the patient is like asymptomatic or mild
Mm-hmm.
headache or mild nuclear rigidity. In the second grade, the patient will be having like a moderate to severe headache and cranial palsy, like cranial cerebral
Mm-hmm.
palsy. In the third stage, the patient will be confused. The
Mm-hmm.
fourth stage, the patient will be in coma or stupor, yeah, coma and hemiparesis. And in the fifth stage, will be morbid condition or rigidity like decerebrate or decorticated rigidity.
So, Doctor, what are the other grades?
The other
Radiological
grade is
classification.
a WFNS classification. It is based on the GCA score and the deficit. It is divided into 5. On grade 1, GCA score is like 15. In grade 2, it is 13 to 14 with no deficit. In the grade 2, it
Okay,
is 13.
Doctor, so you know what WFNS class. So, what's the significance of Fisher and modified Fisher classification? What does it show? What?
The Fisher and modified Fisher classification. Sorry, I'm not getting your
So,
question.
you don't know. So obviously, the Fisher and modified Fisher classification are based on CT scan, and
Yeah,
they
it's about
showed
the
and
vasospasm. Yeah, the vasospasm.
yeah. So, do you remember that class?
Vasospasm.
Do you remember that classification?
Um, the Fisher. No, I don't remember that one.
So you need to go and read Fisher and modified Fisher classification, and it is basically a classification that talks about the amount of blood, and the greater the blood, the greater the amount of vasospasm. So, what do you see in the angio? What sort of an aneurysm is this?
Yeah, in the angiogram,
Mm-hmm.
this is an aneurysm. Is like at the junction or terminal junction of ICA and MCA.
No, Dr. Saab, this is not the junction of ICA and MCA. Look at it again. Look at the scan again. This is a lateral view of the ICA, and it shows an aneurysm. It is not an ICMC, but it's not an MC aneurysm. So it is, yeah.
ICA.
No, Dr. Saab, it is not ICA. So, Farooq, can you point out? Yeah. So this pointer, this is the aneurysm. The
It's
vessel
an
before that
MCA
is
aneurysm.
no, Doctor. This is not an MC aneurysm. This is an ACOM aneurysm, an anterior communicating artery aneurysm, because this is a lateral. This is a lateral view, and you see the ICA, and then you see the A1, the anterior cerebral artery. So so what is
Where
the
is the
management?
ACOM in this?
Obviously, you cannot see the ACOM, but you can see the A1. And if you look at the amount of blood, so this is an ACOM aneurysm. Obviously, this is a lateral view, so ACOM is not that visible, but you can clearly see the A1s and you can clearly see the A2s. So, what is the treatment for a ruptured ACOM aneurysm?
सर टाइम
What
खत्म
are
हो
the
गया
treatment options? Just आखिरी 1 मिनट क्या उस्ताद क्या what is the क्या treatment options है aneurysm की
So first of all, we like
endovascular.
to stabilize the patient and vascular clipping and coiling.
अच्छा अगर एंडोवास्कुलर कॉइलिंग वाले कहते हैं कि हम नहीं कॉइल कर सकते, तो फिर अगर जब क्लिप करोगे तो क्लिप करते हुए एक ऑर्गेनिज्म को जब क्लिप करते हैं, व्हाट आर द वेसल्स दैट यू नीड टू लुक एट? कौन सी 8 वेसल्स होती है जिनको देखना होता है बिफोर यू क्लिप एन एनेरिज्म? 8 या 9 होती है?
I would like to see the A1, A2, the MCA, the recurrent artery of Hubner,
एमसीए भी देखोगे एक
ICA.
एनेरिज्म में?
No, ICA. Like
डॉक्टर साहब
first we will go.
डॉक्टर साहब टाइम खत्म हो रहा है, सो यू नीड टू सी, सॉरी I'm sorry, I'm cutting you in between, but you need to see both A1s. You need to see ACOM. You need to see bilateral A2s. आपको recurrent देखनी होती है, frontopolar देखनी होती है, तो ये before you clip the aneurysm ये सब vessels देखनी जरूरी होती है, सही है? So I suggest कि go back. There's a book called 7 Aneurysms. उसका छोटा सा चैप्टर है, उसमें ये सारी वेसल्स के नाम लिखे हुए हैं, एंड व्हेन यू लुक एट द एंजियो जस्ट मेक श्योर कि वो एंजियो का इमेज कैसा है, जिस तरह वो आप उसको एमसी समझ रहे, तो वो एमसी नहीं थी, बेसिकली वो एंटीरियर कम्युनिकेटिंग आर्टरी का एन्यूरिज्म था और वो लैटरल व्यू था। सही है। सो गो बैक, लुक एट द एंजियोस।
जी डॉक्टर
इस
साहब
तरह
आप
के होंगे एग्जाम में। सही है।
ओके, so thank you everyone, or especially the examiners, Dr. Naveed, Dr. Tanveer, Dr. Rabil, Dr. Saqib was here, and Dr. Pirasat from Hyderabad, he was here, Dr. Yasin was here, Dr. Fatma was here. Unfortunately, they had to leave earlier. But अभी हमारे साथ डॉक्टर तनवीर हैं, डॉक्टर राबेल हैं, I guess, and डॉक्टर नवीद हैं, और फिर डॉक्टर साद भी हैं. So we want a very quick comment from each of you. डॉक्टर राबेल, मैं आपको अनम्यूट करूं, पहले आप.
सॉरी टू इंटरप्ट फरूख, आई हैव टू लीव. तो मैं चाह रहा था कि अगर मैं
चले, मैं आपको
छोटा
सर
सा,
ज्यादा टाइम देना चाह रहा था इस वजह से, बट खैर यू कैन स्टार्ट.
so I can start with it, and
Yes,
then of course I'll talk and then leave. Okay.
ओके सर. जी
So
सर.
we do it case by case, यानी generally मैं बात
सर
करूं.
जनरली सर अभी इस वक्त
Okay.
बस वाइंड अप करने को.
So my first case was I don't remember the name, लेकिन it was it was a case of pineal region lesion था, जो कि उसके multiple of course options. तो सबसे पहली बात जो what I learned from just on a lighter note, my chief is here. Dr. Saad used to be my chief. So वो एक काम करते थे हमारे साथ, सजा कह लें या जो भी. So वो एग्जाम के दिनों से पहले he would take us to his room, और हमारे जो एग्जामिनेशन रूम्स या उसमें, और just he would put up some scans from even, मतलब कहीं जाने की जरूरत नहीं है, just scans from internet or anywhere जिसमें images हों सिर्फ, and he would say कि just try to describe it. एंड उसका फायदा क्या है कि बोलने से आपकी बेसिकली वो रिपीटिशन, कुछ आर्टिकुलेशन की जो है वो बेहतर हो जाती है, और यू नो व्हाट यू आर टॉकिंग अबाउट, बट ऑफ कोर्स आर्टिकुलेशन होना बहुत जरूरी होता है. कुछ बहुत पेट सेंटेंस होते हैं, पेट लफ्ज होते हैं जो रेडियोलॉजी इस्तेमाल करता है, एंड यू नीड टू नो कि वो मैंने कब बोलने हैं. फॉर एग्जाम्पल अगर सीटी स्कैन है तो यू यूज हाइपोडेंसिटी, कट्स कौन से हैं, मतलब व्यू कौन सा है, ये देखना. इसी तरह T1 में, T2 में. देन यू ऑल्सो, बिकॉज इन टोक स्टेशंस अमूमन जो आपके पास पिक्चर दी होती है, यू डू नॉट हैव टाइम कि आप आस्क यू कि जे मुझे सैजिटल कट चाहिए, एक्सियल चाहिए. दे डू नॉट हैव दोज कट्स जनरली इन टोक्स में जो चीज आपके पास पड़ी भी है, स्पॉट डायग्नोसिस प्रॉबेबली वही होता है, और यू डू नॉट हैव द ऑप्शन टू. तो उसमें पर्टिकुलरली ये चीजें और ज्यादा इंपॉर्टेंट हो जाती हैं. फॉर एग्जाम्पल अगर आपके पास सिर्फ पोस्ट कंट्रास्ट स्कैन लगा हुआ है, तो यू कैनॉट कमिट 100% कि ये कंट्रास्ट इनहेंस कर रहा है, बिकॉज इट वाज अ पोस्ट कंट्रास्ट इमेज और T1 नहीं था. So I know high chances that lesion was contrast enhancing, but don't commit, say we do not. बेहतर ये है कि इस तरीके से आप बोलें कि although we do not have T1, but probably it is contrast enhancing as per my assessment. तो जब तक आपके पास T1 नहीं है, उतने तक कंट्रास्ट एनहेंसमेंट आप 100% नहीं कमिट कर सकते. एक बात. दूसरी बात ये कि जहां की भी पैथोलॉजी होती है, आपका जब टोक्स होता है, आप जनरल एनाटमी को डिस्कस करेंगे तो बहुत टाइम जाया होगा. रेडियोलॉजी में जो आपका केस है उससे रेलेवेंट एनाटमी डिस्कस करना बहुत जरूरी है. फॉर एग्जांपल अगर पाइनियल का लीजन है, तो ड्यूरिंग दैट रेडियोलॉजिकल जो एक्सप्लेनेशन है, यू नीड टू नो कि लोकेशन क्या है, कंप्रेशन किस जगह पे है, वेस्कुलर स्ट्रक्चर्स पर्टिकुलरली वीनस स्ट्रक्चर्स वो दिख रहे हैं या नहीं दिख रहे. बिकॉज इन लेटर ऑन इन दोस क्वेश्चंस इनकी सर्जिकल ऑप्शंस की बात हुई. तो अगर आपने रेडियोलॉजी में नहीं देखी कि वीनस स्ट्रक्चर उसने कहाँ पर डिस्प्लेस किया हुआ है, तो उतने तक आप 100% कमिट नहीं कर सकते कि इस केस में मैं कौन सी सर्जिकल ऑप्शन ऑप्ट करूंगा. फॉर एग्जाम्पल, इफ इट इज पोस्टीरियरली वेसल्स जो हैं वो डिस्प्लेस हुई हुई हैं, तो आप ऑक्सीपिटल या फिर वो अप्रोचेस नहीं ले सकते, बिकॉज as you go in you will find vascular pathology right in your face before going into pathology. So you have to make sure कि जो relevant pathology है सिर्फ उसी को डिस्कस करें. In that case, of course we had pineal gland lesion, तो आपको उसको क्लासिफिकेशन थोड़ी बहुत आनी चाहिए. फॉर एग्जांपल pineal gland lesions जो हैं वो आप जर्मिनल सेल जीसीटीज जिसे कहते हैं, जर्मिनल सेल ट्यूमर्स में डिवाइड करते हैं. उसके बाद आप पाइनियल के पैरेन्काइमल ट्यूमर्स हो सकते हैं. Then there are of course glioma and meningiomas, and then there are miscellaneous lymphomas वगैरह, ये सारी चीजें हो सकती हैं. लेकिन probably in that case जिस तरह का लग रहा था, probably it was a germinal cell tumor. And in further classification you can say that germinal cell tumors are germinomas and non-germinomatous germ cell tumors, choriocarcinomas, teratomas वगैरह. और probably अगर आप इस तरह करके क्लासिफिकेशन देंगे तो यू हैव टाइम ऑल्सो, लिमिटेड टाइम, बहुत डीप नहीं बताएं, लेकिन एटलीस्ट टच देंगे तो लोगों को पता होगा, एग्जामिनर को अंदाजा हो जाएगा कि ही नोज हिज स्टफ. देन उसकी नेक्स्ट प्रोग्नोसिस भी बेसिकली क्लासिफिकेशन के हिसाब से ही है. सो जर्मिनल सेल ट्यूमर्स में अगर जर्मिनोमास हैं, ऑफ कोर्स उसके CSF वर्कअप जो है वो जरूरी है. उसके साथ उसमें मेनली 3 चीजें, अल्फा फीटोप्रोटीन्स, बीटा HCG एंड ऑफ कोर्स अल्कलाइन फॉस्फेटेज जो है वो आप उसमें देख सकते हैं. सम पीपल आल्सो डू साइटोलॉजी, लेकिन बहरहाल दैट्स एन ऑप्शनल थिंग. उसके बाद once you have the CSF, next question was कि prognosis कैसा है. So prognosis would also depend on classification जो आप suspect कर रहे हैं, and then age उस patient की was 20 years. So if in kids and in young patient prognosis germinomas की अच्छी है, क्योंकि वो एक तो you just need a biopsy and then chemotherapy, radiotherapy can take care of it. And then prognosis के बाद follow up basically. So follow up in young kids, मतलब kids and young patients is lifelong in those patients. तो ये छोटी छोटी चीजें आपको अंदाजा होनी चाहिए. मतलब नॉन जर्मिनोमेटस सेल्स की प्रोग्नोसिस इतनी मतलब स्लाइटली एग्रेसिव ज्यादा है. मेनिंजियोमास हैं तो कंप्लीट रिसेक्शन बेसिकली, या उसका बेस्ट प्रोग्नोसिस कंप्लीट रिसेक्शन से है, लेकिन गिवन दैट एरिया समटाइम इट्स नॉट इजी टू डू, तो वो आप बायोप्सी करके जस्ट मेक श्योर, देन स्टीरियोटैक्टिक रेडिएशन हो सकती है. सो 2-3 चीजें जो मेनली उस केस में थी वो ये कि रेलेवेंट एनाटॉमी इज वेरी इंपॉर्टेंट, एंड ट्राई टू रेडियोलॉजी को जितना आप डिस्क्राइब ज्यादा करेंगे उतना ज्यादा आपको ये रेलेवेंट टर्म्स सीखना आसान होंगी. और वो आपको उसको मतलब जितना ज्यादा बोलेंगे तो उस टोक्स के लिमिटेड टाइम में आपका टाइम बचने की उम्मीद ज्यादा है. So that can happen. If I remember, the second case was a brain lesion जो कि supratentorial था, hypointense on T1, hyperintense or T2. उसमें radiology just to start with, डॉक्टर साहब said it may be an infective कुछ बोला था शायद, I don't remember, मेरे ख्याल से some cyst उन्होंने कहा था. तो दैट्स वो इन्फेक्टिव सिस्ट बेसिकली, उसमें आपको फिर डिफेंड करने के लिए कुछ होना चाहिए. हाइड्रेटेड सिस्ट, यस, ही सेड इट मे बी हाइड्रेटेड सिस्ट. सो हाइड्रेटेड सिस्ट में जनरली यू हैव सेप्टेशंस, यू हैव डॉटर सिस्ट्स. तो वो उसका दिखना या एटलीस्ट उस हो सकता है इट कैन हैपन दैट इट्स अ हाइड्रेटेड सिस्ट, लेकिन सेप्टेशंस नहीं है, डॉटर सिस्ट नहीं है, तो उसको आप डिफेंड करना मुश्किल है कि वो क्या हो सकता है. दूसरा ये कि देन ऑफ कोर्स जो रेटिनॉइड सिस्ट की क्लासिफिकेशन है वो देखना जरूरी है कि जी टाइप 1, 2, 3 है बेसिकली. आप इंटरवेंशन कब करेंगे ये बहुत जरूरी है. इंटरवेंशन ऑफ कोर्स हैज टू बी व्हेन द पेशेंट इज सिम्टोमेटिक, या फिर वो बहुत ज्यादा एग्रेसिवली ग्रो कर रहा है विद टाइम, और सिम्टोमेटोलॉजी शो कर रहा है, तो ऑफ कोर्स दैट यू कैन ट्रीट विद. और देन अगर स्कल बेस की तरफ ज्यादा है, CSF स्पेसिस के करीब है, तो इट्स ऑलवेज बेटर टू open it up, either openly or matlab microscopically or endoscopically into that cisterns. And if it is more onto superior area जहां पे cisterns के साथ वो connect नहीं कर रहा, या मतलब grade 3 है, तो उसमें it's better to do it as a shunt or complete, मतलब आप उसको open up into spaces, उसके बाद भी आप shunt place कर सकते हैं, but cystoperitoneal is a better option in those cases. So of course DWI, उसमें एक major question ये था कि diffusion weighted आप करवाएंगे या नहीं करवाएंगे, और of course एसोसिएटेड कोई स्कैन्स, तो उसमें DWI का बेसिकली वो पूछना चाह
नवीद साथ यार, बस जस्ट इन योर लास्ट स्टेटमेंट जस्ट कंक्लूड ये करो कि टोक्स के लिए ये लोग आखिरी दिनों में ऐसा क्या करें कि इनका बेहतर हो जाए. तुमने बताया कि इमेजेस खोल के देखें, आई थिंक दैट्स द बेस्ट वे फॉरवर्ड.
Yeah, so it's just 1 week left, I think. कहीं जाने से और घूमने फिरने से, वो टाइम जाया करने से, इट्स बेटर कि जस्ट मिल के बैठे भले. ट्राई टू, यू कैन हैव मल्टीपल केसेस नेट पे, आप उनकी इमेजेस डाउनलोड करके एंड जस्ट टर्न बाय टर्न उसको डिफाइन करें, एंड अदर योर कॉलीग्स कैन आस्क यू क्वेश्चंस अबाउट. सिमिलरी क्वेश्चंस होते हैं, डायग्नोसिस क्या है, ट्रीटमेंट ऑप्शन क्या है, DDs क्या है, प्रोग्नोसिस क्या है. दूसरा ये कि ऑफ कोर्स टोक्स में थोड़ी सी स्टडी इज एक्सटेंसिव, सो एंड इट्स बेटर वेरी, खास तौर पे आप जब से थोड़ा बहुत सिस्टम चेंज हुआ है. पहले ये होता था कि अगर आप टोक्स में क्लियर नहीं है, देन यू वुड हैव अ चांस टू appear in vivas also. I think that system has been changed now. So if you don't go through talks, you don't appear in vivas as well. So talks को appear करना इसलिए जरूरी है बहुत ज्यादा कि so you have a chance at long cases as well. Of course लाजमी नहीं है कि हर किसी का पहले अटेम्प्ट में ही क्लियर हो, लेकिन if एटलीस्ट अगर आपका टोक्स क्लियर है, तो यू हैव अ बेटर ऑप्शन कि जी आप अगर फर्ज करें इस साल नहीं हुए, तो नेक्स्ट टाइम यू हैव अ टच ऑफ योर लॉन्ग केसेस एज वेल. सो आई वुड रियली से कि जी थोड़ा बहुत स्टडी, ऑफ कोर्स बुक के हिसाब से टोक्स में ज्यादा जरूरत है, एंड विद मतलब कहीं जाने से बेहतर है कि घर बैठे या फिर किसी एक एरिया में बैठे, स्टडी एरिया में बैठ के रिपीटिशन करें उन केसेस की. देयर वेरी स्मॉल नंबर ऑफ केसेस जो के आते हैं.
थैंक यू सो मच
Thank you.
डॉक्टर नवीद, एंड आई कुड सी कि आप जो है ना वो स्टार्ट से अब तक बैठे हैं, and that's so nice of you, and I guess everyone enjoyed your discussion and your comments as well.
So thank
So
you.
Dr. Rafael, sorry, जी.
Just because I'm going on a lighter scan, I mean lighter way, डॉक्टर साद जो है वो आए, और आते साथ ही उन्होंने मुशर्रफ का वाइवा लिया, तो मैंने कहा मुशर्रफ का वाइवा साद के अलावा और कोई नहीं ले सकता था.
नहीं यार, I must congratulate and thank Farooq who covered, who did everything, क्योंकि मैं I was at CPSP and he did an excellent job, and I think
I agree.
he मतलब obviously stepped up and he सारा टॉक्स उसने प्रिपेयर किया, तो I think and उसने ये भी इसने आखिरी में डॉक्टर मुशर्रफ ने कहा तो मैंने लिया, बट बहुत छोटा सा था. बट आई थिंक डॉक्टर नवीद ने जो बात की है कि रेडियोपीडिया होता है, उसमें इमेजेस खोले और शुरू हो जाए, बोलना शुरू हो जाए.
जी डॉक्टर राबेल, a very quick comment from you.
From the 3 stations that I got, and by observing the whole talks, the whole practice of the talks in this session, I want to say कि मतलब talks में the main thing is that you have to stay to the point, because we only have 5 to 7 minutes to convey what we know to the examiner, and इसमें बिल्कुल basic कुछ questions होते हैं, and they're not really that hard, and वो theoretical Greenberg में और हर book में ना वो available हैं, वो लिखे हैं. So just have control over your nerves, be to the point, be specific, एंड जो क्वेश्चन पूछ रहे हैं उसका आंसर देना, एक्स्ट्रा नहीं देना, बिकॉज इतना टाइम नहीं होता. जो लॉन्ग केस होता है उसमें तो रेडियोलॉजी कैन describe radiology in great detail, but in short you have in talks and short cases you have to be very specific and बहुत specific जो उसकी findings होती है ना उसको to the point रह के सिर्फ important चीजें ही बतानी होती हैं. because if we go here and there ना तो examiners जो है उस चीज को लेके ना फंसा सकते हैं, फिर वो out of the question चले जाते हैं. तो it's very important to stay within the line and मेरे ख्याल से सब बहुत very well prepared थे. they were giving to the point answers एंड जो है वो एक्स्ट्रा कुछ भी नहीं बोल रहे थे. तो जस्ट स्टे फोकस्ड ऑन दैट. एंड अभी लास्ट के फ्यू डेज है ना, तो आई वुड रिकमेंड इज दैट सिट विथ योर फ्रेंड्स, सिट विथ पीपल यू हैव बीन स्टडीइंग विद एंड डिस्कस डिफरेंट थिंग्स, बिकॉज हर किसी से ना कुछ न्यू इन्फॉर्मेशन मिल जाती है. तो व्हेन यू ब्रेनस्टॉर्म एंड यू सिट टुगेदर एंड यू डिस्कस डिफरेंट सिनेरियोज, डिस्कस डिफरेंट इमेजेस, तो उससे न्यू आइडियाज एंड न्यू चीजों के आंसर्स मिलते हैं, एज कम्पेयर टू जस्ट सिटिंग और going to different wards and looking at different patients. It's better to have a healthy discussion with the people that you have been studying with.
जी डॉक्टर तनवीर, आई डोंट नो if you are available, अगर आप अनम्यूट हो सकें.
क्या
जी
आवाज आ रही
डॉक्टर
है मेरी?
जी, बस शॉर्ट सा कमेंट काइंडली.
हाँ, ओके ओके. फर्स्ट ऑफ ऑल थैंक यू फॉर इनवाइटिंग अस. और बहुत सारी चीज़ें वैसे ही डिस्कस हो चुकी. डॉक्टर नवीद ने भी बताया, डॉक्टर साद ने भी, और मैं भी यही कहूँगा कि मेरे पास भी 3 स्टेशन थे. ब्रेन एब्सेस था, एक एक्यूट एसडीएच और पिट्यूटरी मैक्रोएडेनोमा. तो जो एग्जामिनर्स और जो कैंडिडेट थे वो अच्छे प्रिपेयर थे, उन्होंने अच्छे आंसर दिए. लेकिन थोड़ा सा एक मैं ये ऐड करूंगा टॉक्स के लिए, जैसे राबेल ने कहा कि आप इसमें रेडियोलॉजी को बहुत डिटेल से डिस्क्राइब मत करें, क्योंकि आपके पास टाइम बहुत कम होता है और एग्जामिनर ने काफ़ी सारी आपसे चीज़ें पूछनी होती हैं. तो बस आपको जो पॉजिटिव फाइंडिंग्स मिलती हैं आप वो बताएं जल्दी जल्दी से, उनको मिस मत करें. और उसके बाद क्वेश्चंस के लिए भी ना स्पेसिफिक रहें. और दूसरी बात ये कि मैंने जो देखा था ब्रेन एब्सेस में खास तौर पे, तो उसमें ये था कि जो कैंडिडेट था, जब उससे बात हो रही थी ना कि आपके पास ऑप्शंस क्या हैं, तो जो भी आपके पास टॉक्स का स्टेशन हो ना, जब आपसे ट्रीटमेंट ऑप्शंस की बात की जाए तो आप अपना जो रेडियोलॉजी सामने है उसी के हिसाब से बात करें. आप एक ओवरऑल मत बताएं कि जो ट्रीटमेंट ऑप्शंस हैं, जो जैसे ग्रीनबर्ग में एक लाइन से लिखे हुए हैं कि आप ये भी कर सकते हैं, ये भी कर सकते हैं. नहीं, वो तो आपको जो उन्होंने सिनेरियो दिया है वो उसके पॉइंट ऑफ व्यू से पूछ रहे होते हैं. तो इससे काफ़ी दफ़ा ये होता है कि आप जो चीज़ें आपके सिनेरियो से मैच नहीं कर रही होती हैं, आप उससे हट के चीज़ें बता जाते हैं और साइड पे जा जाते हैं. फिर एग्जामिनर आपको उन्हीं चीज़ों के अंदर ही वो फंसा देता है. तो इस चीज़ का ख्याल रखें. बाकी दूसरी बात यही है कि अब आपके पास लास्ट वीक है, तो मैं आपसे यही कहूँगा कि मोस्टली यही होता है, लोग वार्ड्स में जाते हैं. मैं मतलब कोई नेम तो काउंट नहीं करूंगा मुझे, लेकिन पता है यहाँ पे कुछ ऐसे भी कैंडिडेट्स हैं जो 2-3 अटैम्प्ट दे चुके हैं, जिनको आइडिया है कि उन्होंने सारे केसेस वगैरह देखे होते थे, लेकिन वहां पे फिर भी एग्जाम में वही केस उनके पास आता था, लेकिन फिर भी मसले आ जाते थे सामने ना. तो अब ये है कि आपके पास ये है कि टोक्स आपको क्लियर करेंगे, फिर ही आपको जाना है आगे लॉन्ग शॉर्ट केस के लिए. तो आप टोक्स पे ज्यादा फोकस करें, ग्रुप डिस्कशंस करें और एक हेल्दी डिस्कशन करें, पॉजिटिव रहें. तो इंशाल्लाह अल्लाह ने चाहा हो जाएगा आप लोगों का.
जी डॉक्टर साहब.
Thank you, Farooq. Thank you again, yeah, for covering for me. I think talks में सबसे important चीज ये है कि एग्जाम में सबसे important चीज है ये बोलने का एग्जाम. एग्जामिनर को नहीं पता चलेगा आपके दिमाग में क्या है जब तक कि वो आपकी जबान पे नहीं आएगी. टोक्स में जैसा ये लोग कह रहे हैं कि एमआरआई से स्टार्ट होता है, और एमआरआई यू हैव टू इंटरप्रेट द एमआरआई, और उसको उसमें बता, जैसा अभी एक बच्चा था वो पिट्यूटरी का एमआरआई बता रहा था, तो लेकिन वो पिट्यूटरी के एमआरआई में यहीं पे रुक गया कि सेलर ट्यूमर है. आप बताएं कि ऊपर थर्ड वेंट्रिकल में जा रहा है, आप बताएं साइड में कैविटी साइड. आई एम जस्ट सेइंग कि थोड़ी चीजें बताएं एटलीस्ट जो कि वो एमआरआई पे उस एमआरआई का हक है. आई एम सेइंग कि इसमें आप जाके अभी इमेजेस खोलें, आपको पूरा पता है कि टोक्स में 15 केसेस आएंगे. डॉक्टर फरूक ने उसमें से 15 से 20 केसेस दिखा दिए. यही केसेस होंगे, यही स्कैन्स होंगे. एक दूसरे से बैठ के सवाल करें, एक दूसरे को ग्रिल करें, बोलने की कोशिश करें, स्कैन पे बोलने की कोशिश करें, क्योंकि ये जो प्रैक्टिस होगी ना, ये एग्जाम के दिन आपको हेल्प करेगी. कि एग्जाम के दिन जब आपके सामने स्कैन रखे ना, ताकि आपको पता हो कि यार मैंने ये बोलना है, बहुत ज्यादा नहीं बोलना. जिस तरह ये कह रहे हैं कुछ सवाल उनको, इट्स लाइक अ गेम ऑफ कार्ड्स. आप कुछ कार्ड्स देते हैं, कुछ वो अपने पास रखते हैं, आहिस्ता आहिस्ता. और कोशिश करें अगर कहीं फंस जाएं तो सॉरी कह के आगे चले जाएं, ताकि आपके बाकी चीजें पूरी हो जाएं. आई थिंक कि इट वाज एन एक्सीलेंट सेशन. आई होप आप लोगों को इससे फायदा हो. वी हैव अ वर्किंग डिनर जिसपे अब हम केसेस डिस्कस करेंगे. देयर इज अ सीनियर एग्जामिनेशन examiner who flew from Lahore just to help you guys. एंड आई अज्यूम एंड आई वुड रिक्वेस्ट कि जो जो आ सकता है उस डिनर पे वो आए एंड आके उससे फायदा उठाए. डॉक्टर फारूक, ओवर टू यू.
बस सर, मैं भी बस ये क्लोजिंग रिमार्क्स ही हैं. सबने बहुत अच्छा केस किया अपना अपना. बट इसमें इशू यही है कि उसके अंदर अगर आपको चीज़ें आती हों तो आपको लगता है कि वो जो 5 मिनट का आपका टाइम है बहुत अच्छा गुजर गया और बहुत जल्दी गुजर गया. बट अगर आपको कुछ नहीं आएगा तो वही 5 मिनट बहुत लंबे हो जाते हैं आपके लिए. सो इम्पोर्टेंट यही है कि आप क्वेश्चन को प्रॉपरली सुनेंगे और प्रॉपरली आंसर देंगे उसी सवाल का जितना पूछा गया है. तो मेरा नहीं ख्याल कि आप कोई भी इशू होगा, और 5 मिनट से बहुत ज़्यादा सवाल पूछे जा सकते हैं. इवन आप देखेंगे कि बहुत सारे स्टेशन ऐसे भी होंगे जहाँ पे आपसे कोई ना कोई सर्जिकल अप्रोच तक भी पहुंच जाएंगे आपसे. सो 5 मिनट्स आर एनफ. लेकिन इंपॉर्टेंट वही है कि आपने रेडियोलॉजी बहुत जल्दी से पिक कर ली और बहुत जल्दी से डिस्क्राइब कर दी. अगर आप रेडियोलॉजी डिस्क्राइब करने में, सिनेरियो को पढ़ने में ही बहुत ज़्यादा टाइम ले लेंगे तो ऑब्वियसली आपके बहुत सारे सवाल मिस हो जाएंगे उसके अंदर, और स्पेशली जब आपको कुछ ना आ रहा होगा तो. सो दैट इज़ वेरी इंपॉर्टेंट. ये हम टॉक्स की बात कर रहे हैं. बाकी इंशाल्लाह कल के सेशन भी हमारे पास शॉर्ट केसेस भी हैं, लॉन्ग केसेस भी हैं, और इसी तरह से इंटरेक्टिव सेशंस होंगे. कल तो कम्प्लीटली इंटरेक्टिव है कि कल कोई लेक्चर नहीं है अलग से. ऑल आर इंटरेक्टिव सेशंस. एग्जामिनर सीनियर होंगे कल मौजूद सारे. ठीक है, आज तो हमारे पास जूनियर एग्जामिनर्स भी थे, बट कल हमारे पास सीनियर एग्जामिनर्स होंगे सारे के सारे, जो कि शॉर्ट एंड लॉन्ग केसेस के लिए होंगे अवेलेबल. सो आप लोग सब जो है वो टाइम से कल कनेक्ट भी हो जाएं. और दूसरा ये है कि एवरीवन शुड इंक्लूड हिमसेल्फ के भाई मैंने ये केस करना है. मैंने काफी देर तक पूछता रहा, और बहुत से लोगों ने जो है जिन्होंने रजिस्टर भी किया हुआ था, हर तरह से कंप्लीट उन्होंने की हुई थी रजिस्ट्रेशन, लेकिन उन्होंने वो हैंड रेज नहीं किया या वो आगे नहीं आए कि मैंने केस प्रेजेंट करना है. सो काइंडली कल आप ये ना करें. लास्ट डे है और उसके अंदर सीनियर एग्जामिनर्स होंगे, तो आपकी बहुत अच्छी प्रैक्टिस हो सकती है उससे अगर आप उनको फेस कर लेंगे तो. अभी
आई थिंक बड़ा इंपॉर्टेंट पॉइंट है जो डॉक्टर फारूक ने रेज किया है कि अगर अभी चुप बैठेंगे, अभी गलती कर लें, एग्जाम में गलती करना गलत है. अभी गलती करने में कोई नहीं है. अपनी झिझक खत्म करें बोलने की. एंड आई थिंक दैट्स व्हाट दिस इज फॉर. हम फिजिकल नहीं कर सके, हम ऑनलाइन कर रहे हैं, तो इसका जितना फायदा उठा सकते हैं इसमें ले, इसमें गलतियां करें, इसमें आए, एग्जामिनर को फेस करें. और आई थिंक आई वुड लाइक टू थैंक डॉक्टर रुआ एज वेल, जो कि हमारे साथ हैं, जिन्होंने डॉक्टर फारूक को हेल्प की इसको अरेंज करने की. इंशाल्लाह ताला कल भी आपको मिलेंगी और हो सकता है डिनर पे भी आपको मिले. एंड डॉक्टर फारूक, अपना कंक्लूडिंग रिमार्क्स. एंड आई थिंक डिनर 7 बजे है, तो आई थिंक वी नीड टू रैप दिस अप.
यस सर, बस बस हम क्लोज कर रहे हैं इसको. और दूसरा ये कि लास्ट चीज कि जो लोग अवेलेबल हैं उनके लिए, और जो लोग अभी कैंडिडेट्स नहीं है इस एग्जाम के लिए, उनके लिए भी ये है कि वो इन सेशंस को अटेंड करते रहें. और होपफुली इनकी जो रिकॉर्डिंग्स होगी हम वो भी अपलोड करेंगे कहीं ना कहीं पे, सो दैट यू गाइस कैन टेक बेनिफिट फ्रॉम इट लेटर ऑन. सो थैंक्स टू एवरीवन. आज के लिए इतना ही. बाकी डिनर पे होपफुली सब लोग आ रहे होंगे जो लोग हैं कराची में, और वी विल सी यू देयर. थैंक यू एवरीवन, एंड डॉक्टर रुआ एज वेल. Sorry, I forgot.